The antidepressant. A commercial lists the symptoms of depression, and explains. While the cause is unknown, depression may be related to an imbalance of natural chemicals between nerve cells in the brain. The antidepressant works to correct this imbalance. You shouldn't have to feel this way anymore. The chemical the ad is referring to is serotonin, a neurotransmitter. Serotonin does many things in the brain and has long been theorized to have something to do with the symptoms of depression. The slightly more complex version is that depression is caused by a chemical imbalance. It means low or abnormal levels of serotonin. Taking an antidepressant, or selective serotonin reuptake inhibitor, SSRI, changes serotonin levels in the brain and makes a person feel better. In the face of this theory, it's easy to understand how a new paper in Nature Molecular Psychiatry seemed like a bombshell. It does a systematic review of studies on serotonin levels in people with depression. It found no evidence that depressed people had lower serotonin levels or abnormal serotonin activity compared to non-depressed people. The Daily Mail reported, today's landmark findings call into question society's ever-growing reliance on antidepressants like Prozac. Do depressed people have different levels of serotonin? The review suggests the answer is no. The new review combined evidence from 17 systematic reviews and studies, with data from hundreds of thousands of people both with and without depression. It found that there was little credence to the idea that low serotonin activity or low amounts of serotonin are associated with depression. This review paper was not designed to probe the psychopharmacological mechanisms of antidepressants, nor their efficacy. Its focus was a narrow one: the relationship between depression and lowered serotonin concentration or activity. For 3 decades, people have been deluged with information suggesting that depression is caused by a chemical imbalance in the brain. It is according to a major review of prior research led by UCL scientists. It suggests that depression is not likely caused by a chemical imbalance, and calls into question what antidepressants do. Most antidepressants are selective serotonin reuptake inhibitors, SSRIs, which were originally said to work by correcting abnormally low serotonin levels. There is no other accepted pharmacological mechanism by which antidepressants affect the symptoms of depression. The popularity of the chemical imbalance theory of depression has coincided with a huge increase in the use of antidepressants. Prescriptions for antidepressants have risen dramatically since the 1990s. 1 in 6 adults in England and 2% of teenagers are now being prescribed an antidepressant in a given year. Many people take antidepressants because they have been led to believe their depression has a biochemical cause. But this new research suggests this belief is not grounded in evidence. Research compared the levels of serotonin and its breakdown products in the blood or brain fluids. It did not find a difference between people diagnosed with depression and healthy control. Comparison: participants. Serotonin. Research was on serotonin receptors and the serotonin transporter, the protein targeted by most antidepressants. It found weak and inconsistent evidence suggestive of higher levels of serotonin activity in people with depression. However, the researchers say the findings are likely explained by the use of antidepressants among people diagnosed with depression, since such effects were not reliably ruled out. The authors also looked at studies where serotonin levels were artificially lowered in hundreds of people by depriving their diets of the amino acid required to make serotonin. These studies have been cited as demonstrating that a serotonin deficiency is linked to depression. A meta-analysis conducted in 2007 and a sample of recent studies found that lowering serotonin in this way did not produce depression in hundreds of healthy volunteers. However, there was very weak evidence in a small subgroup of people with a family history of depression, but this only involved 75 participants, and more recent evidence was inconclusive. Very large studies involving tens of thousands of patients looked at gene variation, including the gene for the serotonin transporter. They found no difference in these genes between people with depression and healthy controls. These studies also looked at the effects of stressful life events. It found that these events exerted a strong effect on people's risk of becoming depressed. The more stressful life events a person had experienced, the more likely they were to be depressed. A famous early study found a relationship between stressful events, the type of serotonin transporter gene a person had and the chance of depression. But larger, More comprehensive studies suggest this was a false finding. These findings together led the authors to conclude that there is no support for the hypothesis that depression is caused by lowered serotonin activity or concentrations. The researchers say their findings are important as studies show that as many as 85 to 90% of the public believes that depression is caused by low serotonin or a chemical imbalance. A growing number of scientists and professional bodies are recognizing the chemical imbalance framing as an oversimplification. There is also evidence that believing that low mood is caused by a chemical imbalance leads people to have a pessimistic outlook on the likelihood of recovery. It may lead to the possibility of managing moods without medical help. This is important because most people will meet criteria for anxiety or depression at some point in their lives. The authors also found evidence from a large meta-analysis that people who used antidepressants had lower levels of serotonin in their blood. They concluded that some evidence was consistent with the possibility that long-term antidepressant use reduces serotonin concentrations. The researchers say this may imply that the increase in serotonin that some antidepressants produce in the short term could lead to compensatory changes in the brain that produce the opposite effect in the long term. The study did not review the efficacy of antidepressants. The authors encourage further research and advice into treatments that might focus instead on managing stressful or traumatic events in people's lives. They include psychotherapy, alongside other practices such as exercise or mindfulness, or addressing underlying contributors such as poverty, stress and loneliness. Professor Moncrief said, "Our view is that patients should not be told that depression is caused by low serotonin or by a chemical imbalance. And they should not be led to believe that antidepressants work by targeting these unproven abnormalities. We do not understand what antidepressants are doing to the brain exactly. And giving people this sort of misinformation prevents them from making an informed decision about whether to take antidepressants or not." Cause of depression. Co-author Dr. Mark Horowitz, a training psychiatrist and clinical research fellow in psychiatry at UCL in Delft, said, "I had been taught that depression was caused by low serotonin in my psychiatry training and had even taught this to students in my own lectures. Being involved in this research was eye-opening and feels like everything I thought I knew has been flipped upside down." One interesting aspect in the studies we examined was how strong an effect adverse life events played in depression. Suggesting low mood is a response to people's lives and cannot be boiled down to a simple chemical equation. Professor Moncrief added, "Thousands of people suffer from side effects of antidepressants, including the severe withdrawal effects that can occur when people try to stop them, yet prescription rates continue to rise. We believe this situation has been driven partly by the false belief that depression is due to a chemical imbalance. It is high time to inform the public that this belief is not grounded in science. The main areas of serotonin research provide no consistent evidence of there being an association between serotonin and depression, and no support for the hypothesis that depression is caused by lowered serotonin activity or concentrations. Some evidence was consistent with the possibility that long-term antidepressant use reduces serotonin concentration." Nature. Although first proposed in the 1960s, the serotonin theory of depression started to be widely promoted by the pharmaceutical industry in the 1990s. It was in association with its efforts to market a new range of antidepressants, known as selective serotonin reuptake inhibitors or SSRIs. The idea was also endorsed by official institutions such as the American Psychiatric Association. They still tell the public that differences in certain chemicals in the brain may contribute to symptoms of depression. Countless doctors have repeated the message all over the world, in their private surgeries and in the media. People have accepted what they were told by the doctors, and they started taking antidepressants because they believed they had something wrong with their brain that required an antidepressant to put it right. In the period of this marketing push, antidepressant use climbed dramatically. For a long time, certain academics, including some leading psychiatrists, have suggested that there is no satisfactory evidence to support the chemical imbalance idea. Others continued to endorse the theory. Until now, however, there has been no comprehensive review of the research on serotonin and depression that could enable firm conclusions either way. First comprehensive review. There has been extensive research on the serotonin system since the 1990s, but it has not been collected systematically before. An umbrella review was conducted that involved systematically identifying and collating existing overviews of the evidence. It was from each of the main areas of research into serotonin and depression. Although there have been systematic reviews of individual areas in the past, none have combined the evidence from all the different areas taking this approach. One area of research we included was research comparing levels of serotonin and its breakdown products in the blood or brain fluid. Overall, this research did not show a difference between people with depression and those without depression. Area of research. Another area of research has focused on serotonin receptors. They are proteins on the ends of the nerves that serotonin links up with and which can transmit or inhibit serotonin's effects. Research on the most commonly investigated serotonin receptors suggested either no difference between people with depression and people without depression. Serotonin activity was actually increased in people with depression, the opposite of the serotonin theory's prediction. Research on the serotonin transporter, that is the protein which helps to terminate the effect of serotonin, this is the protein that SSRIs act on, also suggested that, if anything, there was increased serotonin activity in people with depression. However, these findings may be explained by the fact that many participants in these studies had used or were currently using antidepressants. We also looked at research that explored whether depression can be induced in volunteers by artificially lowering levels of serotonin. Two systematic reviews from 2006 and 2007 and a sample of the 10 most recent studies, at the time the current research was conducted, found that lowering serotonin did not produce depression in hundreds of healthy volunteers. One of the reviews showed very weak evidence of an effect in a small subgroup of people with a family history of depression, but this only involved 75 participants. Very large studies involving tens of thousands of patients looked at gene variation. It was including the gene that has the instructions for making the serotonin transporter. They found no difference in the frequency of varieties of this gene between people with depression and healthy controls. Although a famous early study found a relationship between the serotonin transporter gene and stressful life events, larger, more comprehensive studies suggest no such relationship exists. Stressful life events in themselves, however, exerted a strong effect on people's subsequent risk of developing depression. Some of the studies in our overview that included people who were taking or had previously taken antidepressants showed evidence that antidepressants may actually lower the concentration or activity of serotonin. Serotonin theory is not supported by evidence. The serotonin theory of depression has been one of the most influential and extensively researched biological theories of the origins of depression. Our study shows that this view is not supported by scientific evidence. It also calls into question the basis for the use of antidepressants. Most antidepressants now in use are presumed to act via their effects on serotonin. Some also affect the brain chemical noradrenaline. But experts agree that the evidence for the involvement of noradrenaline in depression is weaker than that for serotonin. There is no other accepted pharmacological mechanism for how antidepressants might affect depression. If antidepressants exert their effects as placebos, or by numbing emotions, then it is not clear that they do more good than harm. Although viewing depression as a biological disorder may seem like it would reduce stigma, in fact, research has shown the opposite. And also that people who believe their own depression is due to a chemical imbalance are more pessimistic about their chances of recovery. Chemical imbalance. It is important that people know that the idea that depression results from a chemical imbalance is hypothetical. And we do not understand what temporarily elevating serotonin or other biochemical changes produced by antidepressants do to the brain. We conclude that it is impossible to say that taking SSRI antidepressants is worthwhile, or even completely safe. If you're taking antidepressants, it's very important you don't stop doing so without speaking to your doctor first. But people need all this information to make informed decisions about whether or not to take these drugs. There are many other hypotheses about how antidepressants may help with the symptoms of depression. They enhance neuroplasticity, or interact with serotonergic activity in brain circuits that are involved in reward seeking and mood. It may be true that academic psychiatrists acknowledge that the links between brain chemistry and depression are more complex. But they have not sought to correct this misconception in the public's minds. Antidepressants can cause side effects, they can be difficult to taper off of. And an over-focus on them as an intervention can deprioritize non-pharmacological or social interventions. Also, sometimes they just don't work. Finally, the harms of the medications outweigh any benefits, and millions of people have been duped into taking antidepressants because of the chemical imbalance narrative. Depression remains a fairly uncertain condition, and people gravitate to whatever half-truths or inconclusive theories appear sensible to them.